Kia ora, morena. It's my pleasure to speak to you today about EB care in New Zealand. I'm not going to talk about EB, and I'm deliberately not using any particular case studies for patient confidentiality reasons. So it's really going to be a general talk about New Zealand and our healthcare system and what we do here. So, as you know, New Zealand's considered a very small country. And part of the reason people think we're small is because we've got a very big brother next door to us, Australia. And I think sometimes people don't realise even how big Australia is. And you can see here, it dwarfs even Europe for geographical size. New Zealand's a little bit smaller than Japan, and we're actually just slightly bigger than the United Kingdom in geographical area. But in population, we're significantly smaller. We've only got 4.6 million people compared to 65.6 million. So we've got quite a lot of space, which we like. And for those of you who've travelled here, you'll know it's tucked away quite a long way on the bottom of the world, right at the bottom of the Pacific. And this map actually shows the way that human migration occurred through the Pacific Islands for colonising the Pacific, with the original people coming down through Southeast Asia, through Micronesia and Polynesia. And New Zealand down here was actually probably one of the last countries in the world to have human habitation, with the first Māori reaching here in 1200 AD. It's about the same time as Genghis Khan and the Magna Carta in the UK. And the first person to discover New Zealand is Kupe. He was a Polynesian explorer from the island of Hawaii. He had great navigational skills, and it was thought he's either coming down in search of better fishing grounds, or personally I like the story that he was chasing a giant octopus. And apparently he caught up with it at the top of the South Island where they had a battle, and he killed it. But the battle marks are left in the shape of the Marlborough Sounds, and you can still see the octopus's eye on one of the rocks out there, apparently. And actually, it was Kupe's wife who discovered New Zealand. She was the one who looked out and saw clouds in the distance and cried, "Te he Aotearoa," meaning the long white clouds. And from that, New Zealand's got its name, Aotearoa, the land of the long white cloud. And that doesn't refer to the weather or the sheep. I'll put that out. And so Māori lived here for more than 500 years without any contact from Europeans. And the first European to reach here was actually Dutch, which was Abel Tasman. His crew reached the top of the South Island in about 1642. The local Māori were concerned they were an attacking force, and they attacked back, killed 4 of his crewmen, and he left without setting foot on land. But he did name New Zealand after Zeeland in the Netherlands. Captain Cook came in about 1769, so more than 100 years later. And he came to New Zealand several times, explored it quite thoroughly, mapped it, and had quite a bit of contact with Māori. And following that, there were progressively more and more Europeans coming to New Zealand for land and for whaling, mainly. In 1840, the British government were quite keen to get hold of this little piece of the South Pacific and make it a British colony. And so they signed a treaty with over 500 of the New Zealand Māori chiefs. That's called the Treaty of Waitangi, Te Tiriti o Waitangi. And this was meant to be a partnership between Māori and the British Crown. It's been a source of conflict over many years. There's been issues with breaches of the treaty and also with interpretation of the treaty, because the Māori version was somewhat different to the English language version. And it's really only since the 1970s, when the treaty was enshrined in New Zealand law, that we've started to try and make attempts to better honour the treaty, and these attempts are still ongoing. Like many First Peoples, Māori health outcomes tend to be a little worse than non-Māori. This graph shows life expectancy at birth for non-Māori females and males in the red and blue, and Māori females and males in the paler colour. And you can see in the 1950s there was a considerable gap in life expectancy. This is improving, but the gap still hasn't completely closed. And that gap still persists even if you control for things like socioeconomic factors or risk behaviours like smoking, and it may well reflect the effects of colonisation and possibly institutional racism as well. And so in the healthcare system, we do try and make attempts to make it more culturally sensitive and friendly for all peoples, but particularly Māori. This illustration is a Māori health concept. They take a very holistic view of health. And this one is called Te Whare Tapai Whā, the house with 4 corners. And the 4 cornerstones of health are considered taha tinana, physical health, taha wairua, spiritual health, taha whānau, family health, and taha hinenaro, mental health. And these sort of concepts, I think, are very important to Māori, but they're actually important to everybody. And we all come from a wider view than just our physical health. New Zealand's not just Pākehā Māori. Pākehā is the word for white New Zealanders. And they make up about 74% of the population. Māori about 15%, but we also have a significant number of Asian, particularly Southeast Asian New Zealanders, and Pacific Islanders who live here as well. Our population's a little bit top-heavy. Over half of the population lives in the top half of the North Island, which means the South Island's even more beautiful, in my opinion. New Zealand has a public healthcare system where money is taken through taxation and used to fund healthcare for New Zealanders. And you could say it's broadly similar to the NHS in the United Kingdom, if you're familiar with that. We have primary healthcare organisations and general practices who provide primary care. Secondary care through hospital systems is largely public funded, though there are private facilities as well for patients with insurance. And we also have tertiary care provided in a number of regional centres for more specialised or complicated services. And the primary health care practitioners act as a gatekeeper for accessing secondary care. So to go to a public hospital, you need a referral from your GP. And again, from secondary care to the tertiary care system, you need a referral from your local hospital to access that in general. The way the healthcare system is run is it's divided up into 20 different district health boards based on geographical area. And the Ministry of Health then provides funding to each of these district health boards for them to use for the population of their area to provide the hospital services and also some of their primary healthcare services. And so people who need to travel to other DHBs for tertiary care, for example, for specialised paediatric care, the local DHB then pays for the other DHB to provide that care. Dermatology in New Zealand is, I think, relatively underserved and underfunded. We have 61 registered dermatologists in New Zealand, but the majority of their practice is in private practice, with only the equivalent of 16 full-time dermatologists working through the public healthcare system. I myself, I'm employed half-time in the public healthcare system. We have very high rates of skin cancer in New Zealand. In fact, I think we even beat Queensland for skin cancer. And a lot of that's provided by GPs, but also by dermatologists. And so patients with skin disease, I think, have a lot of issues with access to public hospital care and specialised care. I work at Starship Hospital, which is the National Tertiary Children's Hospital. It's based in Auckland. It's reasonably big for a children's hospital, but a relatively small hospital, which it means working there is really nice because I pretty much know all the other doctors and we work very collaboratively and very collegially, which is wonderful. We have most of the paediatric subspecialties, medical specialties, surgical specialties, as well as things like transplantation services. And I work in the paediatric dermatology department, which is very small. I'd say we're the smallest department. It was just me at 0.5. We now have a couple. We do have a couple of other dermatologists who each work less than a day a week, and we're hoping to get another one start with us next year at 0.4, which is 2 days a week. And And we run some EB clinics, which I run along with the EB specialist nurses. And it's much of a phone a friend if we need other services to come and help with our patients. So we work with dentistry, ENT, genetics, and we've also had wonderful support from our colleagues in the neonatal care unit, particularly the cultural support workers who've been really valuable in helping us care for some of our very sick newborns. I do get contacted for advice from other dermatologists and paediatricians around the country, and also internationally. I seem to be the person of choice for the Pacific. So we also look after the islands, and actually one of our nurses travelled out to one of the Pacific Islands to care for a newborn with EB, which was really wonderful of her to do that. I also have to acknowledge the support that we get here from our international colleagues, and it's really very helpful for Day or Marcel or the people in the UK to give us help and advice when we need it. Deborah New Zealand has on record about 117 people with EB in New Zealand. There possibly may be more who don't belong to Deborah. And the majority, of course, have the more mild forms, EB simplex or dominant dystrophic EB. But we do have a number of people with more severe forms as well. Since I've been working for about 8 years here, we've had a number of infants born with very severe forms of EB as well, which has been difficult. We do have a wonderful EB nursing service. This was established back in the early 2000s and initially funded through Deborah New Zealand, but now with the Ministry of Health funding. And we have 3 nurses, part-time, but they're spread over the country, and they do a wonderful job of travelling to visit people in their own home and to support them with visits to health professionals or if they're admitted to hospital. They've also written a really wonderful guideline for care of a newborn infant with EB, which is available for all the national neonatal units. You can't talk about EB without talking about Deborah. And Deborah New Zealand, I think, has been an amazing organisation for people with EB in New Zealand, offering very practical support, social, emotional, financial support. I think you guys do a really wonderful job. And I just wanted to make a shout out for some of your special techniques. The saline bathing I've found very useful for people with other diseases as well. It's been really helpful. But like all healthcare systems, we struggle with issues of money. I don't know anyone anywhere that doesn't struggle with issues of paying for healthcare. One of the things that's quite unique about New Zealand is we have a system called PharmAC. This is a pharmaceutical management agency, or drug buying agency, as we like to call it. And their aim is to get the best value for money out of our drug budget in New Zealand. So they have a process of a very managed schedule of medications, which doctors are allowed to prescribe, fully funded. And then they go out and they competitively tender between the different pharmaceutical agencies to try and get the best cost. And because of this, we've been able to drive down our cost of our pharmaceuticals. If you look on this graph, this is spending per capita in US dollars. This is the OECD average here in pale red. US here at the top, winning again, and New Zealand down here. And there are some flaws with the PharmAC model, but it's also got a lot of advantages for us, and so I think it's something we should continue to work with. Bandaging for EB patients in New Zealand is available, funded by their local DHBs, and they can access many of the specialised wound care products. There's a bit of variability of access between different DHBs for various bureaucratic reasons. And I think we also need to look at how we can streamline things in terms of minimising waste, not having expired bandages left unused and those sorts of things. I think one of the things that sort of caused a lot of people to have a bit of a rethink, not just in EB, but with a lot of medical conditions, was the effect of the Christchurch earthquake back in 2011. This was a devastating event for Christchurch. 185 people killed and a large part of the central business district destroyed. And there was quite severe disruption to infrastructure, loss of power and water for quite some days. And as you can imagine, in trying to perform dressing changes or even just general cares for somebody with EB, this was quite challenging. And there was also, with the roads disrupted, there was difficulties with getting deliveries of new supplies. And so this highlighted to many people the need for an emergency plan, adequate supplies to cope for a few days until help can be obtained. So I think in New Zealand we do face a number of challenges, but I think we've also got some opportunities in EB. I think one of our challenges is we do have a relatively small patient population, and they're spread over quite a big geographic area. And we're starting to use more technologies to help us with managing that, and also with getting advice from overseas as well. And we also have an issue a little with engaging with patients and clinicians in terms of getting advice. We get a bit of late presentations in crisis, and we get a bit of a problem with clinicians not referring patients early enough. And I think really we have to work on trying to get better engagement with the rest of our colleagues around the country with that. We don't have a centralised multidisciplinary care clinic at the moment in New Zealand, and we've given some thought as to how we could do that, but it's technically and strategically quite challenging with the way the funding models are. But it is something I think we should continue to consider and look at. I think one of the challenges that's going to come in the future, or is happening now, is really with the advances of care, and particularly with some of these new genetic techniques. Some of these are going to be very expensive, and how we can access those for our patients in a realistic way is going to be quite challenging. I think the best thing we can do from a clinical perspective is try and use more evidence-based practice. That means that we use techniques which have shown to be helpful for people and discard techniques which haven't been shown to be helpful, so that when we are spending money on healthcare, we're doing it in the most efficient way that we can. And so I think really the future looks quite bright. Be positive, and I look forward to working with many of you ongoing in the future. Thank you.